So tonight, I think we have a very special presentation for you before we begin to enjoy some poo-poos in the cafe. But I'd like to bring up Ryon Nakasone here. Ryon, we actually had to get him to commit to cut his honeymoon short. He was married 2 weeks ago, and he agreed to come and speak to us this evening. As you see, he's going to be addressing a cancer topic and approach to cancer. And just as a quick reminder, Dr. Nakasone is a JABSOM graduate of the class of 2006. He's an associate clinical professor in our Department of Medicine, and he's been a practicing hematologist here in town. He earned his bachelor's degree in cell molecular biology from Manoa, and after he graduated from JABSOM, he did his internal medicine at the University of Hawaii Internal Medicine Residency Program. But because we don't have an oncology fellowship yet, Dr. Nakasone had to leave Hawaii and completed his training at the Scripps Clinic in San Diego, then came home to Hawaii where he's part of a private oncology group but continues to teach our students and treat our patients here in Hawaii. So please give a warm welcome to Dr. Ryon Nakasone.
Hello, everybody. I know I don't look like your typical Nakasone. I'm actually faking it. No, I'm kidding. I'm a quarter Okinawan, although you cannot tell, and I'm 3/4 Portuguese, of which you will tell. I want to first thank the Dean for honoring me with this ability to speak to you folks this evening. I am truly humbled to be up here because I look around this room and I see so many amazing community members. I see former faculty of mine, mentors of mine, tutors of mine, true giants in the field of medicine. And I'm honored to be able to stand on their shoulders and help the people that I help because they took a chance on me many years ago, including Dr. Satoru Izutsu, who interviewed me in 2002, and he's like, "You're Nakasone?" And he's looking at his file, he's like, "This gotta be the wrong guy." But I cheated and I got in. So I was asked to give a talk tonight on cancer and the advancements of cancer that we've had in such a short amount of time, and it's such a gigantic topic, but they wanted me to keep it interesting. How do you talk about chemotherapy and cancer and those sorts of things and keep it interesting? But I will try my best to do so. And don't worry about the slides, I just have them to help myself. Again, I'm 3/4 Portuguese, so I tangentialize all the time. So it helps to keep me very linear. And I talk a lot with my hands, which is a genetic predisposition. So please don't worry if you see me gesticulating like crazy. What you have to remember too is all oncologists truly are eternal optimists in a pessimistic world. If I can get a study that proves I can let the patient live 7.2 days longer, that's a win, right? And so we're always looking for the best options for our patients, no matter what they may be. Like Dean Hedges alluded to, I'm a true local boy. I was born and raised in Kailua. I went to St. Louis High School, thank you, right? UH Manoa for undergraduate, JABSOM for medical school, UH for residency. I did a chief resident here. I just didn't want to leave. But I knew 1,000 years ago in the 8th grade that I wanted to do medical oncology and hematology. So in order to do that, I had to go to the mainland. But I came back as fast as I physically could. The 8th grade changed my life the first time. That's the first time I read about cell division, cell biology, and what it meant for a cell to truly grow and divide. And then I read about cancer, and it literally blew my mind. One cell in your body amongst billions can acquire one single mutation, and it can mutate and become deleterious. It can become a very evil cell that can divide and grow and ultimately end and threaten somebody's life. And to me, that was just mind-blowing. How is that even possible? I thought our bodies and our reproductive processes are perfect. And we come to find out that it's not. And so I wanted to learn more about cancer. And this is going to sound super depressing, but I was watching movies about cancer and reading books about cancer and volunteering at hospice, for example, to meet people with cancer and hear their stories and hear their family stories. And it truly, truly changed my life. And I knew back then, at the age of 12, what I wanted to do with my life. And luckily, 7 years later, here I am. No, I'm joking. A lot of people ask, how can you do oncology? Because it can be very depressing. But I counter that with, we are there at the deepest, darkest moments of people's lives when they're fighting for their life. And we are there to be their cheerleaders and their support system. We're there to help them and their families. And that is truly one of the most rewarding times in a person's life, in my career, in my life. And so I don't think it's depressing at all, because we're trying to battle with them every step of the way and really make an impact in their lives. I thought this quote from a breast cancer warrior was a very interesting quote. It says, "The devil whispered in my ear, 'You're not strong enough to withstand the storm.' Today I whispered in the devil's ear, 'I am the storm.'" And this is truly, truly empowering, because we hear it from our patients all the time. I'm going to fight this, I'm going to beat this, I'm going to do it for my loved ones. And we're there to try to help them as best we can. The scope of the problem, though, is growing. In 2020, the estimates are there's going to be about 1.8 million new cases of cancer every year, this year, of which 7,000 are going to happen in the state of Hawaii. The main four have been the same for decades: breast cancer, prostate cancer, lung cancer, and colon cancer, and it accounts for almost half the cancer cases. And even though we've gotten better with our therapies, we've gotten better in prolonging people's lives, and we've gotten better at managing side effects and toxicities, we haven't found the cure. Chemotherapy, as the word first came about, started in the early 1900s, and it referred to any therapy that used chemical to treat a condition. Initially as for antibiotics to treat any kind of infections, but nowadays, of course, we use it for our chemotherapy and treatments that we use for cancers and other malignancies. For millennia, surgery was the way to try and treat cancer, right, if we can cut it out. And I mean no disrespect to any surgeons in the audience, but you're not as good as you think you are. No, I'm joking. Right? Dr. Murayama's going to shoot me, and Dr. Mugi, she's going to strangle me. But surgery and radiation therapy, actually, for many, many decades, were the cornerstones of cancer treatment. Chemotherapy really didn't come into its own until after World War II, for example. Studies were emerging that showed chemotherapy can further enhance the cure rate in patients who couldn't be cured by surgery and or radiation by itself. Cure rates were plateauing around 25 to 30% with surgery alone, for example. But it became the three pillars of cancer care at that time: surgery, radiation, and chemotherapy. And some people got all, some people got one, some people got two. The era of modern chemotherapy really came about in the early 1940s in the World War II. And it actually started with a German air raid in Italy by complete accident. There was a German air raid that knocked over nitrogen mustards, and it exposed multiple Italian soldiers to this toxin. And what they were seeing is these people were getting extraordinarily sick, and their bone marrows were getting very suppressed by this chemical. And so these two anybody from Yale? Because let me tell you, these people are genius. Goodman and Gilman, two clinical pharmacologists at the time, heard about this, and they heard the fact that this chemical, this nitrogen mustards, could suppress bone marrow. And they tried to start tweaking it and think, well, can we use that therapeutically? And at the time, it was mind-blowing, right? Who would think about introducing a toxin like that to a person to try and help them? But in 1943, they convinced a thoracic surgeon who had a patient with a lymphoma who was so large and was compressing their airway that they were soon to die. They convinced this surgeon to take a chance and to expose them to a nitrogen mustard. Again, radical thinking at the time, but the rest is history, and that's how modern chemotherapy was born. That lymphoma shrank significantly, improving the patient's symptomatology. And from there, the era of chemotherapy really took off. Don't worry about this timeline, but it's just showing you how, since the early 1900s, the development of chemotherapies as we went on. Again, starting in the 1940s, the 1950s, and the 1960s, we're really developing drugs, discovering drugs, and learning more about chemotherapies and how they worked. Nothing good came out of the 1980s, including hair and including clothing. But the 1990s, though, right, the development of chemotherapies really took off again, right? Again, we're not going to get quizzed on this, but this is just an example of the cell cycle that I studied in the 8th grade that really got me interested in oncology. And as you can see, every step of the cell cycle, we have a chemotherapy that can inhibit it, that can target it. Our chemotherapies are directly cytotoxic. They have to get into the body, they have to get into the cell, and they have to disrupt that cell cycle in order to cause damage and hopefully kill the cancer cell. Unfortunately, though, the healthy cells are exposed to the chemotherapy just like the cancer cells. So that's where a lot of our side effects and toxicities come from. Hair loss, low blood counts needing transfusions, increased risk of infection, nausea, vomiting, etc. These are your healthy cells trying to deal with the chemotherapy that we're exposing them to as well. So can we do better? So a lot of scientists in the 1990s started to think there has to be something better than these traditional chemotherapies. We have to be able to help people and minimize the toxicities. How can we try and target the chemotherapy to more specifically the cancer cells and less to the healthy cells? And so they came up with what was called directed therapy or targeted therapy. So on one side of the slide, you see it's just generalized chemotherapy, which blankets the body and tries to kill any cancer cell. But we started to develop these things called monoclonal proteins or monoclonal antibodies, which are proteins that can kind of seek out specific receptors on the cancer cells to try and really target the killing of the chemotherapy to that cancer cell. And this, again, was game-changing. Really increased cure rates, decreased toxicity, and really developed the next step in the generation of chemotherapeutics that we use for our cancer patients today. But even beyond that, people were thinking, why can't our immune system do anything against cancer? It fights viruses, it fights bacteria, it fights fungal infections, but why can't it fight cancer? And a lot of people think it's because cancer cells figured out a way to evade our immune system because a cancer cell is just your normal cell that became abnormal for whatever reason. So they started to develop immune checkpoint inhibitors that I'm sure you've been seeing on the news. And please do not freak out about this slide, right? You're not going to get quizzed on it. So what this slide is basically saying is that cancer cells have developed receptors that can interact with cells of our immune system and basically shut them down, right? So that you can evade our immune system intentionally. Very, very, very clever cells. But then we have scientists that are also clever as well and very ingenious. And they develop drugs that can actually target this interaction and prevent this interaction, which allows our immune system to stay revved up and stay charged up and to be able to attack the cancer cells. So you're manipulating your own immune system to then go and do the work and do the damage and try to kill the cancer cells. Another example of just mind-blowing experimental work that had true clinical benefit and has been very life-changing and life-saving. That doesn't mean to say that just because it's more targeted, there's no side effects or toxicities. Unfortunately, any of our therapies have risks. And you don't have to memorize this slide at all, but it just shows you that any organ system, even with our more targeted therapy, is still susceptible to potential side effects. So does immunotherapy work? And the answer is basically yes. This is just a snapshot of one of the more recent studies that came out showing in squamous cell and adenocarcinoma, which two of the most common forms of lung cancer, the benefit of adding immunotherapy to our traditional chemotherapy. So what this slide is trying to say, in the top cell, for example, 1 year overall survival when you just use traditional chemotherapy, at best was about 48%. When you added immunotherapy to that targeted therapy, it increased that 1 year overall survival to 65%. Again, not 100%, and again, not a cure. But if you're in that 17% difference between the people in the 48% versus 65%, life-changing. The median overall survival, meaning the length of time that about 50% of the people will still be alive, again, with chemotherapy alone, 11.3 months. We're adding immunotherapy to get to 16 months. That doesn't sound like a large benefit, but giving that person and that family that extra time together with minimal toxicities is just a huge, huge, huge benefit that cannot be put in words. Yeah? And again, that squamous cell carcinoma, which is one of the more stubborn cancers to treat, very difficult to treat, doesn't respond to a lot of our traditional chemotherapies. And this was truly, truly game-changing in the world of squamous cell carcinoma. If you look at adenocarcinoma on the bottom, same thing, 49% 1 year survival, adding the immunotherapy took it up 69%. So again, a 20% margin that increased people alive at 1 year's time. And this is in the metastatic setting, which again is technically not curable. CARs is one of the newest therapy. And so I don't know if you guys have heard of CAR therapy, chimeric antigen receptor. Don't worry about the words, it's a lot of jumbled words. But again, this is the next level of what research has truly taken us to, manipulating your immune system. And so what it does is it takes the T lymphocytes, or the T cells from your immune system, and you suck it out of the body, you mail it to the mainland, and on the mainland, they infect it with a virus, okay? In that virus is a gene, and that gene is gonna code for a protein. It infects your T lymphocytes, injects its gene into its DNA, and those T lymphocytes start to grow receptors on its surface. They get the T cells mailed back to you via UPS. It comes to your clinic, and then you infuse it back into the patient. And now these charged up T cells then go out and, like heat-seeking missiles, try to attack that protein that you've programmed it to attack. Truly, truly life-changing work. These CAR therapies have only been out for the past couple of years, but the clinical trials that we're seeing on it and the data that's coming out of these trials are amazing. In refractory lymphomas where patients have no other options, we're seeing clinical response rates above 50%, which is truly, again, amazing. Numbers we have never seen before for these patients. Some are calling this revolutionary. I'm one of them. Some are calling it expensive. It can be anywhere between $400,000 to $500,000 for therapy like this. We anticipate, of course, the price to come down in the future. But again, for a person who's really trying to struggle for every second of life, the price tag means nothing to them, right? They're trying to hold on to their lives and their loved ones. So from the 3 pillars of cancer care, it's grown over the past 30 years to the 5 pillars of cancer care. Surgery, radiation, and old-fashioned chemotherapy still have a role, of course. But now we can add to that targeted or precision therapy, and now immunotherapy is on. So we have multiple different ways of attacking cancer, and I can only imagine where research is going to take us in the future for available other targets to attack. All this boils down to JABSOM itself being life-saving and life-changing, okay? Physicians are on the front lines no matter what role you play. You're the ones in the ditches trying to help patients, help their families as best as possible. And JABSOM is here pumping out physicians as good quality and as fast as they can to try and replace the shortage that we have here in the state. There are just so many things to know, and the learning style, the PBL curriculum here at JABSOM is truly an amazing way to learn. And it really is something that you take with you the rest of your life in terms of lifelong learning to help you educate your patients and help you take care of your patients. JABSOM provides the tools to succeed, and I am definitely a product of that. It prepares you for the future and helps fill the shortages. In my group alone, there's 9 of us, and 7 of them are JABSOM grads. So as you can see, the people who train here want to stay here and take care of the population that we love and the population we've grown up with. I want to thank you guys all again for listening, and I want to thank you all for the support of JABSOM and the support of our future physicians and the support of the community at large. Thank you guys very much.